So I'm going to actually call up Elisabeth to the microphone and the other panelists for our next talk. It's actually me first, I think. Yeah, sorry. So this is a little bit of a model that we're trying. The concept here is we're going to present an illustrative case and then immediately open up for questions. We're trying to... The case is probably less important than the subject of what we're calling the phenotypic-genotypic challenge, and we're hoping to get some discussion going. We may not conclude on anything, we may have a war break out, but we're hoping to open and start discussion on this sensitive issue. None of us have any conflicts of interest to disclose that are relevant to this talk. I thank Elisabeth for finding this slide online. It's provocative in a way, but this is a Pandora box, and the idea is that it's a box of worry and evil and lots of problems that could be open, which I'm worried about by bringing this up today. But as the legend goes, realizing that the Pandora box allowed evil to escape into the world, it was quickly closed, and what we are left with is hope. So I'm hoping that at the end of the discussion we come away with some other questions and research ideas and so forth. So we're going to present the case for a few minutes, and we're going to immediately open up the discussion. So go ahead.
Donc, en consultation, on a rencontré une femme de 46 ans qui consultait pour des fibromes, puis aussi qui avait une ménorragie importante, qui avait une persistante anémie, puis qui avait toujours de la fatigue. Donc, c'est une femme qui avait des menstruations sévères qui duraient 10 jours avec des changements de serviettes sanitaires chaque 2 heures. Elle avait aussi une historique d'échymose facile, des saignements aussi qui étaient prolongés après des coupures. Elle s'est plainte aussi qu'elle avait eu des saignements prolongés après une intervention dentaire en jeune âge et qu'elle avait eu aussi une hémorragie postpartum retardée. Aussi, dans le passé, elle avait eu une polypectomie utérine sans complications puis sans préparation hémostatique. Son ISTH bad score est de 8. Pour ce qui est de ses laboratoires, en fait, son hémoglobine était basse à 94, sa ferritine est à 4. On a dosé aussi son coagulogramme, l'INR était à 1,12, donc il est à une limite supérieure normale. La PTT aussi est à 34,8. En fait, on a procédé au dosage des facteurs intrinsèques et extrinsèques. Puis la particularité qu'on peut voir, en fait, c'est que le facteur 7 est autour de 64% et diminué par rapport aux autres facteurs. Pour ce qui est de l'historique familial, en fait, c'est une dame qui disait que toutes les femmes dans la famille avaient des ménorragies sévères. Dans le fond, à la suite de son historique familial, de ses saignements prolongés menstruels, puis aussi à son taux de facteur 7 qui était diminué à 64%, on a procédé à la biologie moléculaire du facteur 7. En fait, ce qu'on a trouvé chez cette dame, c'est 5 variations génétiques de forme hétérozygote qui sont associées à une diminution du facteur 7. Donc, ce qu'on a fait pour prendre en charge les ménorragies, on a administré du sulfate ferreux 2 fois par jour, du cyclocapron aussi pour contenir les saignements. Malheureusement, la dame était peu compliante au cyclocapron, donc ça a été difficile d'optimiser le traitement par la bouche. L'équipe de gynécologie aussi a été impliqués dans l'historique de soins. Ils ont donné du Provera pendant 3 semaines. Malheureusement, il n'y a aucune amélioration. Ils ont procédé aussi à une ablation de l'endomère. On a préparé la dame avec du cyclocapron intraveineux avant la procédure, mais malheureusement, ça a été aussi un échec au traitement. Donc, à partir de ce moment-là, l'équipe de gynécologie a proposé une hystérectomie abdominale totale, puis la dame a été préparée avec du cyclocapron intraveineux. Elle n'a pas nécessité aucun traitement de remplacement pour le facteur 7 ni de transfusion sanguine, puis elle a eu une perte sanguine de 350 cc suite à la chirurgie. Elle a repris aussi du fer par la bouche pendant 3 mois ensuite à la chirurgie. Son hémoglobine a monté à 119, puis sa ferritine à 45. La dame a aussi amélioré sa qualité de vie parce qu'elle n'a eu aucun autre saignement par la suite. Donc, à main levée, on aimerait savoir qui pense que la dame a une déficience en facteur 7?
Juste par lever de main.
Par un lever de main. Donc, OK. Puis, qui pense que, dans le fond, elle n'a aucun trouble de la coagulation?
Les gens n'osent pas de voter.
Oui. OK.
So most people didn't answer. It's a hard one.
OK. So, comme dans notre centre, en fait, ça a suscité plusieurs questions pour savoir, dans le fond, quel diagnostic est-ce qu'on donnerait à la dame. Donc, dans le fond, établir le diagnostic est très important parce que ça va justement ça va considérer en fait sa prise en charge. Quel traitement hémostatique est-ce qu'on va lui donner? Ça se présente avec un saignement ou si elle n'a pas de saignement du tout? Est-ce qu'on va aussi procéder à un dépistage familial? Comment est-ce que le diagnostic va impacter aussi la dame, la prise en charge? Est-ce qu'elle va discuter de ça avec ses assurances? Comment aussi on va l'inscrire dans le CBDR? Donc, à partir de ce moment-là, on aimerait vous inviter justement au micro pour pouvoir discuter du cas avec nous.
So I'm just going to recapitulate the issue here. So we have a patient who has a bleeding diathesis, NYD. We went into detail to investigate her and found nothing, as we heard as a nice segue from Michelle Scholzberg just before, which is often the case. And going back in her file and with the family history, we noticed that just pattern recognition-wise that her INR and her PTT were at the high range of normal, which brought us to do factor levels. And it's true that the 7 is normal, but it is the lower of all of them, which brought us to do molecular diagnostics for an academic reason. And we found 5 genetic variations that are all associated, they're all heterozygous, but they're all associated with a decreased production of factor 7. So we're not here to discuss necessarily why we did the molecular biology testing as much as we are to discuss in an era where we have genetic testing that is going to be more and more at our disposal. We're going to have results like this. We're still missing a lot of information as to the contribution of lowish factor levels on bleeding. The perfect example, there are more clear examples in carriers of hemophilia. We know that factor levels of 50 and 60% in carriers of hemophilia can be associated with clinical bleeding. And there is preliminary data from the United States showing that low levels of other factors can contribute to clinical bleeding. And here we have now some genetic evidence that this patient is probably incapable of having a higher factor 7 than she has and may or may not be contributing to her bleeding phenotype. So we don't know. So I guess what we wanted to do is start opening up discussion about genetics, about phenotype, and measuring and the inconsistencies that we're going to be faced with in the future. So if anybody dares to come up to the microphone and start the discussion, we'd be very happy. John, no? Okay. Because you answered that you were, I'm picking on you because you answered that you would have called her factor 7 deficient. Would you like to just comment on that?
Well, I think she has the polymorphism for having low factor 7, and I think by itself probably it hasn't caused the symptoms, but in conjunction with other factors, she can certainly do that. I think it's a contributing factor more so than just because of that single factor alone.
And then that begs the next question then. So if we think that it may be a contributing factor, what do we do? What treatment are we going to offer this patient? The same thing is for a carrier of hemophilia who has a 60% factor level who's bleeding. It's sort of the same discussion. So what would you do to treat her?
Well, I would probably use the common hemostatic methods like tranexamic acid to start with, and probably, if it's menstrual bleeding, then probably oral contraceptive pills to start with, and
so non-specific agents.
Yeah.
Well, I like maybe to make some comments. Does it work?
Yeah.
Yeah. I mean, factor 7 is a very unique factor. It's a small molecule, 50,000 Dalton, the smallest one of the vitamin K-dependent factor, which has, to me, several interesting aspects. One is clinical, one is biological, and one is molecular. On the clinical side, clearly we see people, especially women, who have no other bleeding manifestation than uterine bleeding. Now, that creates by itself a problem with using the standard scoring system for bleeding. Now, another point is on the biological side. On the biological side, Well, we are all taught at the medical school that there is no correlation between factor 7 level and the bleeding tendency. There is usually no explanation in the textbook about this, but this is a fact that we all know about and repeat to our students. I believe there is one interesting aspect that to me is probably responsible for this discrepancy. And probably the most important one is that we measure factor 7 with an prothrombin time system that is based on a thromboplastin. And we are using different kinds of thromboplastin. Human brain, which is the reference at the World Health Organization. And then we're using ox brain, we're using rabbit brain, we're using placenta, human placenta, and we're using recombinant thromboplastin. All of them with different types of tissue factor and different level of tissue factor and different mixture of phospholipid. So this is by itself something that will not make me surprised if we come up with an answer that does not really correlate with the clinical biology. And moreover, we are using a product, a thromboplastin, that has at least 1,000-fold more tissue factor than the biology in vivo. Biology in vivo calls for between 1 and 5 picomolar of the tissue factor. And all the thromboplastin that we are using have in the nanomolar range of concentration of tissue factor. So at least 1,000-fold more tissue factor in the in vitro system that we're using to measure factor 7. Would that be surprising if that doesn't correlate with the in vivo system? Probably not. Now, on the molecular side, of course, as mentioned, well, here's a molecule that has 9 exons, and that has genetic variants in the upstream and in the downstream of the molecule. And the upstream of the gene, well, there are at least 5 polymorphisms. Some of them increase, this is not the case here, increase the production of factor 7, others decrease the production of factor 7. They sometimes come one by one, they sometimes come as a group in haplotypes. With a different combination of these different polymorphisms. So no surprise that it's not easy to interpret the result that we have here, and this is not easy to make a correlation between biology and between molecular biology and clinical bleeding tendency.
You know, and I think one of the issues is that also perhaps 65% is adequate in most situations, but you know, faced with maybe hemostatic challenges from surgery or menstrual periods, it's possible, especially with dependency on the exposure of tissue factor and the importance of tissue factor in uterine bleeding. It could be that 65% is not enough, and we're going to see more and more heterozygous states or lowish factor levels that contribute to bleeding, if not in the postpartum hemorrhage literature. So the difficulty is going to be how to manage patients in whom now this particular case she had 65, but we could imagine another case where her INR is slightly elevated and her factor level is at 50% or 47%. And the issues are going to be, how do we call these patients? We're already having that controversy in von Willebrand disease for borderline levels. It's going to beg the question in other deficiencies, even when the correlation between laboratory values and clinical bleeding is even less clear, as Dr. Rivard just pointed out. Manchu.
Well, I just wanted to make a comment.
Oh, sorry.
Even though it isn't so terribly common, do we not have a history of a lot of over the years of a lot of premenopausal women being on vitamin K antagonists, and their factor 7s are certainly not at 65?
Well, again, this is hard to tell. As I just stated, when we're measuring 7, we are not always doing the same thing. And by the way, there are mutations also, which this person doesn't seem to have, that will give us an entirely different result in doing assays if one is using rabbit or human thromboplastin. So here, this lady has 65%, but if I want to be consistent with what I just said and what the textbook says, there is no correlation between what we assay and the bleeding tendency.
The other thing I thought of is that, remember, people use recombinant 7A once a day for prophylaxis for inhibitor patient, and it works. So that led people to actually look into why, and one of the findings was that there's also some extravascular tissue binding and stay there. So the question becomes, when you have a different level, is it because a different kind of binding as well that might explain some of the symptoms?
Well, there is one other issue that I did not mention. Is that factor 7 circulates in plasma at the usual level of roughly 10 nanomolar. Now, activated 7 circulates in plasma at very variable concentration between 1 and 8, 9, 10 nanomolar, 0.1 nanomolar up to 0.8 nanomolar. And what is the responsible contribution to this? Well, there are several. Hormone is one, triglyceride is another one. So here is a situation where, again, it is hard. Of course, if one has lots of 70 in circulation, this person would be at lower risk of bleeding than somebody who has the same level of 70. And another thing that is interesting, by the way, is that the constant of affinity for tissue factor between the 7 and 70 is exactly the same. So as a consequence, non-activated 7 behaves like an anticoagulant by competing with 70.
Yeah, so the ratio is about 10 to 1, I think, and no doubt in terms of binding to tissue factor, 7 actually displays 7A.
Absolutely, because the same constant of affinity for the binding site.
Just as a comment and just to follow up before I let Don ask his question, just following Michelle's presentation, I mean, it was a very nice segue to the discussion here, because whether we believe or not that she's deficient in some way or relatively deficient in factor 7, this creates a lot of problems for entry into CBDR. It creates issues with what she calls her self-identification. She's calling herself, I think I might have factor 7 deficiency, but I don't know. A bit like the comments we saw in Dr. Scholzberg's talk just before. So it does create a lot of problems, and I don't think we all have all the answers today, but I'm very interested to hear what maybe somebody in social work would think, or nursing. Don?
Hi, I'm Don Houston from Winnipeg. So I'm going to play the devil's advocate because that's why you invite me here. So why do we think this woman has a disorder of hemostasis? Why is this not an autosomal dominant disorder of endometrial function?
The answer is it may be. We don't know. This was just an illustrative case to bring up the issues around genetic testing, and we're going to be finding a lot of things that we didn't find before when we look at heterozygotes and things like that. So we're not concluding today that she has a bleeding diathesis, and that was our first question. Do you think, or does she not have? But it begs the question about what we're going to be finding and how that what the impact is for the patient and her bleeding history. So I don't know. We don't have the answer. The question is could it be? It might be a contributing factor.
Well, this is an interesting point, and I believe that, of course, this is not easy to investigate this, because, as one knows, uterus is a major site for production of PGI2, and between the vein and the arteries in the vein, there is a discordance of about 20-fold for a PGI2. So uterus is and of course we know that there are situations where some women are high producer of PGI2 and they do bleed and bleed nowhere else than their uterus. This is an interesting question.
Shannon?
Hi, Shannon Jackson from Vancouver. I'm just thinking about what you're saying and feeling the dilemma of having someone carry a factor first card and present that even to another hematologist. And it strikes me as something like what might happen with the factor 11 patients, where you see these sort of heterozygotes and they carry around this number. And people who don't do a lot of hemostasis are wanting to fix them with plasma, or with either plasma or even more so with factor 11 concentrate. So how do we bridge that dilemma, worrying that people are actually going to get thrombotic events if we allow the system to overtreat them?
And I'll tell you, I had this dilemma when I got those results. It's almost like I didn't want to see them because but at the end of the day, I didn't know what to call her. And so I didn't give her a factor first card. I saw her twice in follow-up, had a discussion with Dr. Rivard. I didn't actually call her anything. And then finally, because I needed to do something, we gave her a card that just talked about what John said, non-specific therapy, so cyclocapron, made no mention of plasma or any factor 7 derivative at all. And the patient's take on it is that I may have a mild factor deficiency or not. And she's okay with that. But in other cases, that might not be the case.
Right.
So some patients may be very uncomfortable, as were we.
And do you think there's is this an appropriate use for that term, undefined or unresolved, that basket of things we don't really know?
I don't know that we even could go that far because, like as Don pointed out, I don't know that there's any, like that might be nothing and it might not be contributing, and how do we know? So I think we're not at the peak of understanding the heterozygote state, polymorphisms, genetic variations, genetics relative to clinical, especially in factor 7. I don't think we know the answer. And before this debate, before this discussion today, Dr. Rivard and I had a talk, and I said, well, what would you say? And at the end, we just both went like this. We don't know. And but it's going to be a dilemma, and we're going to be faced with this more and more as time goes. So I don't think we can say hemostatic issue NYD here, because I don't even know that she has a hemostatic defect. So happens we probably did a little bit more than the usual panel that we should, maybe shouldn't have done, but it's done. And so I think that, we're going to see this more and more. Yeah.
I have to say that this is quite common, in fact, because
I've seen 3 similar cases.
We have sequenced, and I say we, that doesn't mean me, but it means Julie Gauthier, who is standing there, have sequenced over 150 cases over the last years, and we come to see this situation more and more. So I think your case is very well taken, and I believe we don't have an answer for the raised issue here.
So like I said, we're going to close the Pandora box in the hopes that we will be able to answer Shannon's question in 5 years from now. Thank you. So